maybe what the patient wants to know isn't, a drawing of the brain and arrows of where their seizures start and then spread. A patient might be more concerned about, well, are there other conditions, or how is this going to affect my relationship with my partner, or my ability to go out to a pub, or, those things that maybe aren't always talked about.
Hello, fellow humans. Today, I'm talking with Wyatt Bensken, an epilepsy-focused epidemiology and biostatistics academic from Case Western Reserve University, US, who has recently released a really very important paper reporting a very high prevalence of psychiatric and physical conditions amongst people with epilepsy, plus racial and ethnic disparities or differences. If you're interested in learning more about Wyatt's amazing project, stay tuned. And if you haven't already, and if you want to, subscribe to the channel and hit the bell for notifications. Together, honestly, let's improve outreach, epilepsy understanding, care, and research. Hello, Wyatt Bensken. It's great to have you here today. Could you please tell everybody a bit about yourself and your work and your exciting paper?
Absolutely, yeah. So thank you so much, Torie, for having me on. It was so exciting to see that this work resonates with folks, especially in the epilepsy community. And so I'm a PhD candidate at Case Western Reserve University in Cleveland, Ohio. I'm an epidemiologist and biostatistician and a population health scientist. So basically what all of that means is that I'm really curious about how we can use data, and especially large healthcare data, to improve, healthcare and health outcomes for everybody. But my big interest lies for people with epilepsy. So, my background is in public health, and then some research at the NIH here in the United States, and that's really where I became motivated to study epilepsy. I think, like most people who don't have epilepsy, I was kind of naive to the field when I first came in, but I realized quickly that it's a condition that has a large stigma, a large social burden, and honestly is rather underfunded from the research perspective.
To say the least.
Yeah, and so I really became motivated to say, well, this seems like a good challenge to take on for my doctoral work and my career afterwards. And so I'm really passionate about how we can use these data to understand both care and outcomes, but disparities as well for people with epilepsy, recognizing that no two people are the same, but that the structures we have in place bucket people into groups based on race, ethnicity, and so how do we understand how disparities occur in a condition like epilepsy, where the consequences to not having access to treatment, to not being properly diagnosed, to not managing those comorbidities could have pretty severe consequences. So that's a bit about me and what motivated me to enter this field and do some of this work.
This is really exciting. So tell everybody about your paper, because you've touched on topics that are very close to my heart. You've come up with empirical evidence, or a large selection of data actually, to basically prove to the world these are the issues. These, as you said, these are the disparities between different groups of people. People need to, governments need to be knowing about this in order to make changes that benefit people. So tell us a bit more about this paper, please.
Absolutely, yeah. So what we did is we used United States Medicaid data, and I know you speak to a large international audience. So in the U.S., Medicaid are those folks who are perhaps low income or have a disability, and so it's a really safety net insurance program. They're really the most vulnerable in our society here in the United States, and so what we did with those data, and we had people with epilepsy is who we had these data on over 5 years, capturing all of their healthcare encounters during those 5 years. And there's been meaningful literature to say that there's this large comorbidity burden among people with epilepsy, that things such as depression and anxiety are very common. But where that's really been limiting and lacking is first understanding racial and ethnic disparities and inequities in the prevalence of these conditions, and then also from a methodological standpoint. And I think a big gap between the research community and the patients, honestly, is that oftentimes what researchers do when we look at comorbidities is we have a predefined list that have been previously published perhaps in a very different context. And generally those are decided based on a relationship to some outcomes. So there's, these algorithms which will say these are the 20 most comorbidities, the 20 most important comorbidities, but the reason they're most important is because they're associated with hospital readmission or emergency department visits. But taking a step back, that may not be what's the most important to a patient. So the word comorbidity implies that you have a central condition, which in this case is epilepsy, and everything else is tangential to that. But really what we're trying to move more towards is this idea of multimorbidity, or these combinations, to say that it's not epilepsy plus hypertension. Maybe somebody's hypertension is actually more important to them because their epilepsy is well controlled, or maybe their seizures are well controlled, but that anxiety and depression they feel is actually more important. So, how do we move away from prioritizing just their epilepsy, but saying this is a whole person. This is an individual with complex care and needs, and that most people don't only have epilepsy. Most people don't only have episy and anxiety, right? There's a real potpourri of conditions that are
potpourri. That's such a polite word.
And they occur in combination and together, and so that's what we sought. We had a couple goals for this paper, but one of them, which I think is really our biggest novel approach here, is instead of using that list of 20 or 30 conditions, we took all the diagnoses that we had available to us, and we used a statistical technique called association rule mining, and I'll just very briefly describe it because I think most people are familiar with it, whether or not you know it. So it's the same technique that Amazon uses when they say other people who bought this, or you might also be interested in this, and what it does is it looks for those combinations in these data. And so
like algorithms.
Exactly. Yep. Yeah. So when you're thinking, well, why does Instagram know I need to buy this, or why does Amazon suggest this perfect thing just because I bought a new Dutch oven for my kitchen? So we use the same thing, and I really love that approach of taking these things that are used in consumer research and saying, how do we apply this to health? How do we better take these tools to understand these complexities in health?
You were talking about how, before we started recording, how mathematics is such an important part of healthcare.
Yeah.
We're never taught this really, unless you're in an academia, maybe not even all of academia. Mathematics and statistics are play a huge part, should they be done well, in improving the lives of people affected by the epilepsies and other conditions and diseases.
Yeah.
Would you agree, Wyatt?
Oh, absolutely. And I think something that our paper shows that hits home is that most of the conditions that we saw, or maybe not most, but at least half that we saw, a neurologist may not be the best position to care for. And so we might think, well, somebody has epilepsy, other than their primary care doc, their neurologist is the person they most frequently see. But, we saw things such as back problems or urinary tract infections that, how do other care providers help care for people with epilepsy? And that's exactly why, without these, kind of boring pages of tables and results, we wouldn't know that. We wouldn't know, how do we transform or reform the healthcare system? How do we make a larger swath of providers say, well, sure, you might specialize in hypertension, but we see this large prevalence of hypertension among people with epilepsy, and so a lot of your patients may have epilepsy. Are you thinking about their epilepsy? Are you asking them how does their epilepsy affect their hypertension control, and thinking about that complexity and trying to put numbers to what people like yourself who live with epilepsy on a daily basis know that it's your life, but putting that to a population scale, and then turning that around and taking it to hospitals, to clinicians, to policymakers, and saying, this isn't just one person's story, this is a population health level issue, hopefully will motivate change at a grander scale.
And because with the epilepsies, I find, and I understand why, but it's not an excuse, but the seizures are the things that clinicians tend to look at. And I totally get it, especially if somebody's at high risk of SUDEP and injury, etc. And especially if you have refractory epilepsy, I totally get it. But often the comorbidities such as anxiety and depression, well, to us, they can be equally, if not more important. And in addition, if these are not addressed, well, we could be missing a trick in potentially reducing a person's likelihood of having a seizure anyway, because you're not so stressed out, right?
Yeah, exactly.
And the same goes for pain, back pain, because you covered back pain in your paper as well. Now, if you're in pain all the time, you're not going to sleep as well, generally. And then if you don't sleep enough, you're more likely to have seizures. So it's like having all these balls, which are like doing this most frustrating little dance, to say the least, and bringing them together, bringing the clinicians and statisticians, did I say the right word?
Yeah.
Together, and just, right, let's put the, the pieces of the puzzle, feels like a puzzle together to provide the best quality of life possible for the patient, the individual, and everyone else. And you'll have, I imagine, I mean, you said that I think a third of people are on, is it Medicaid or Medicare?
Medicaid.
Heaps of them, Medicaid, right? Heaps of them, I bet, are likely to get off Medicaid and possibly get into work, or at least part-time work maybe, or even if they only do voluntary work, or for instance, they are still contributing to society and the economy, and, possibly going to be taking less drugs if everything's, well balanced. So all these statistics, once summarized and analyzed by you, are incredibly powerful.
Yeah, and I think you hit on such an important point there about particularly anxiety and mood disorders. And so we found a much higher prevalence than other studies have reported. So we found 46.5% of folks in our study, so basically half, had an anxiety and mood disorder. And I want to, some of the nitty gritty of our methods are that all of our data come from what's being billed. And so I think that's particularly powerful, because what that 46.5% really means is that 46.5% of people have talked to their doctor about their anxiety and their mood disorders, and the doctor has then diagnosed them with that and then billed the insurance for that. And so how many folks are walking around of that remaining, 63.5%, how many actually do have anxiety about their seizures, about their epilepsy, and thinking through how this might change care, and thinking, well, somebody might lose their job or not be able to work because they're worried about having a seizure. But if you're able to help with that anxiety, is that gonna bring it to a point where they, as you said, they could work, half time or even back to full time? Is it actually their epilepsy that's preventing them from doing what they want in life, whether that be education or work, or is it these comorbidities? Is it that anxiety, depression, mood disorders? Is it the back pain because they're at home, because of that anxiety? There's a real cascade.
And they're not moving, and then they might, our muscles can become floppy instead of nice and firm.
Yeah.
And then you can't say, okay, core strength, that's what I was thinking.
Yeah.
Your core strength might not be like the best of the best.
Absolutely. And I think, we've all got a taste of this during the pandemic of, you're like, oh, I haven't been outside in 3 days. I need to go for a walk, or, particularly early on when we were all really being told to stay at home. But, the fact that this has been going on for decades for people with epilepsy who are, not afraid to leave home, but we've created a society that can be unwelcoming, and there's medical systems that don't always appreciate this complexity. And what I want to emphasize, and what we wrote in the paper, is that I'm not trying to claim that it's a neurologist's job to manage anxiety and mood disorders, hypertension, back problems, developmental disorders, headache, injuries, all these things, but recognizing, certainly in the U.S. healthcare system, that there's other specialists out there. There's also generalists. There's primary care providers. In the U.S. we've seen over the past 30, 40 years this movement away from primary care and more towards specialists, but taking a step back and saying, well, primary care could be a better mechanism for somebody whose seizures are well controlled. Maybe they don't need to see their neurologist as often if their seizures are well controlled, but maybe as they get older they develop hypertension like a lot of us do, and so their neurologist may not know how to manage that hypertension, but the relationship between the heart and seizures is being pretty well established now, that during seizures there's heart rate variability, And those concepts, and is that driving? There's so much complexity here. It's kind of like a ball of yarn, and what we were trying to do is maybe not untangle the ball of yarn, but say, oh, this is where the line goes, and this is how it's tangled up. And maybe instead of untangling it with one care provider, we can pull the ball of yarn apart and say, okay, you tackle this part, you tackle this part.
It's like a ball of skanky yarn, actually, I think. And it's like we can dilute the skankiness and make it into nice something and knit it something pretty.
Exactly.
If we put those skanky bits of yarn to the right clinician or professional.
Exactly.
Yeah. And reduce the pressure, I think, because many, neurologists or epileptologists are under such, and actually most people I speak to in this sphere, under such pressure, feeling they have to deal with everything, because we don't have the resources yet, or not sufficient resources to provide people with the specific clinician they need. It makes me think of neurologists that I've had experience with, and I know many other people have, who might be a generalist, which is great, but they can't provide the care that person with refractory epilepsy and the whole shebang needs, or their personal interest might be, say, stroke.
Yeah.
And although strokes can certainly be linked to epilepsies, it's not, their primary interest. So we need to have these professionals, it's like we need a CRM system, isn't it, to be able to direct people to the right individual automatically. And it's a bit of a wishful thinking, but, it would save our government's money.
Yeah.
It would bring money to the economy.
Exactly.
It would reduce mental health issues.
Yep.
It would be positivity all round.
Yeah, and that's exactly what, I'm hopeful that the clinicians in your audience can take away from this, is just saying, we report the top 10 and combinations and stuff, but really I think what I hope people will take home, the clinicians, is saying, how many times do I ask my patients with epilepsy, well, what's your primary health concern right now? How many times does an appointment start not by saying, oh, have you been taking your seizure medications? How has your seizure control been? But saying, how have you been? How have you, maybe the seizures for some folks are well controlled. They get on that right medication after trial and error. They've undergone surgery or implantation, but now it's the anxiety, or maybe it's, they're having some hypertension start to emerge that's actually causing them more discomfort. And so, taking a step back and saying, asking those patients with epilepsy, because we know that there are so many other conditions that play a role here, and we saw injuries rise to the top, right? So certainly maybe the seizures are the concern, but really, is somebody more afraid of that injury than they are the seizure, right? They're more afraid of the result of the seizure. And so, that's a really different, you have to manage both, but then the conversation's about, well, tell me about, do you live with people? What's your apartment like? What's your home like? Are there ways that we can make you feel more comfortable while we find that right medication for you, rather than saying, well, the injury's the result, we have to address the seizure, and I'll see you in 6 months. How do we do something that can really improve that interim and that care, and also empower people to say, I'm being heard, that these things that anxiety I'm feeling is being validated and is being heard and is being addressed.
You're really making me think about how a huge thing I think is left out often is when somebody is diagnosed, they don't understand their own condition, right? That it's new to them, most of the time it's new to them or new to the one that they love. And I feel that we need to be taught how to talk about our own medical condition to other people. Yeah. Because say, for instance, I had a focal seizure in a pub, right? Even today, I'd be like, oh my goodness, did I do anything weird during that seizure? What are people going to think of me? Now I can deal with that now. But in the past, I would still be, even though I could speak very confidently about my epilepsy, I would still be like worried, oh my goodness, what's happened? Especially for a tonic-clonic seizure, like lots of people, defecate, wet themselves and stuff, and you don't know how other people are going to react. So I do wonder sometimes clinicians missing a trick when somebody's diagnosed, how can we educate this person with epilepsy or the family affected so that they can explain it to others comfortably and without being, stressed or worried that they're going to be judged or chucked out of their social circle or, and things like that. Confidence through education is a really big deal with epilepsy, I think.
Absolutely. And understanding how to communicate that. And, I feel like we've done such a good job in mental health conditions of really starting to talk about that and saying that, how does somebody, a lot of the cognitive behavioral therapy and those options for anxiety and mood disorders are based around helping somebody understand their condition. And that alone can really just empower somebody, can actually bring the anxiety down by saying, this is what's going on in your body. This is the biologic mechanism that's making you feel this way. And somebody says, oh, it's kind of terrifying, but it's kind of cool. And we've done that so well in some fields, but not in epilepsy. And also understanding, I think, we know so much about epilepsy, but at the same time, we know so little. And it's such a mystery. And being able to communicate that uncertainty, I think, is so important in saying that, here's what we know, here's what we don't know, but also recognizing that maybe what the patient wants to know isn't, a drawing of the brain and arrows of how, where their seizures start and then spread. Certainly they might want to know that, but a patient might be more concerned about, well, are there other conditions, or how is this going to affect my relationship with my partner, or my ability to go out to a pub, or those things that maybe aren't always talked about, that can drive that anxiety and those mood disorders and depression, and which can lead to then hypertension and back problems. And again, it's a cascade and this web of things that really taking a patient-centered approach is I think so critical.
I can see this beautiful world if, this all occurring if we have the funds to do it.
Yeah, exactly.
And can encourage people who we need to be involved to become involved. The world could change for so many people. And I wonder how many more people would be diagnosed if the world was a better place for people with epilepsy. Wouldn't that be interesting?
Absolutely, yeah.
What are you going to be focusing on now? Now you've published this paper, what are you going to take from that? And what's your next project, or how are you using this data for your next project?
There's a lot of places I think that we can go with this. So this was a really descriptive study that was really bombarding the reader with data. And we do synthesize a lot of it, and we touch on a lot of things, right? So we touch on the combinations of conditions, those racial ethnic disparities. We touch on utilization, and for those folks who are in the top quartile, the top 25% of utilizers, how we saw that among those, the prevalence of anxiety and mood disorders was actually 75%. So, those folks that are interacting most with the healthcare system have way higher needs. So we really did like kind of a big descriptive data dump here for two reasons. One, very selfishly, because we have so many avenues of kind of inquiry that we want to pursue, and this lays the groundwork, but we also want to be able to give other folks the ability to say, well, my specialty is migraine, and I want to do research on epilepsy and migraine, and here's a paper that's going to help justify how I can go get funding from, the NIH or NHS or whoever that their institution or country's funder is to do that research. And so for us, our next avenue are to take these data and to see, we were talking beforehand, or maybe at the start of this podcast here about outcomes and how so many times we use lists of conditions that have been associated with outcomes. And so I don't always think that's great because the inherent limitations from a patient point of view, but the reason that we do that is if we can show that these outcomes affect hospital readmission or emergency department utilization or costs, or even medication adherence, which then adherence affects utilization, ED visits and such. So my next next studies here are thinking about these conditions that we examined and how do we relate them, how do we relate the complexity that we lay out here to a complexity in outcomes? Because we've talked about that need for these data not just to speak to patients and caregivers and clinicians, but policymakers. And if we can show that these conditions or these combinations increase somebody's risk of hospitalization or emergency department use, then that now has an incentive to say, okay, so we're going to compensate neurologists and primary care docs for managing this complexity. We're gonna take a fraction of the cost and move it up front, and we're gonna save this money. So that's really the next step for us, is to make that next step in this line of inquiry to say, and here's the ultimate consequence of ignoring what we have for so long.
Right, so it's going to cost the taxpayer, the government, the whatever their title might be, money, and a lot of money,
Yeah.
And those in the positions of power do know that no matter the continent upon which you're on right now, we will vote for you if you do the right thing. That's what it's so please, and if you've got any questions for Wyatt, I'm sure he'll be very, very happy to take them. If you, I don't know if there's any sort of news media people on here, but if so, I guess get in touch with Wyatt, because Wyatt has the data to back up these claims. This is empirical evidence showing that investment in care for the people affected by these different conditions and diseases is going to benefit the human population, to be honest. So let's sort this out, right?
Absolutely, yeah. And one thing I do want to touch on too, we won't go too depth into it, and it's in the paper, those racial and ethnic disparities, right?
Right.
That these conditions don't, the prevalence of these conditions are not uniform, and some of that could be true disparities due to structural factors, but also recognizing that some groups, some populations, if you have a white healthcare provider, which is most care providers in the United States, a minoritized patient may not feel comfortable talking with that provider. That provider may have implicit bias that, their seizures are due to poor medication adherence, not due to refractory epilepsy, to drug-resistant epilepsy. And so what we also presented in the paper, and I think is really important, are these disparities, in that it's not uniform. It's not as though one racial and ethnic subgroup always has the highest prevalence. It really varies based on condition, because of those structural factors which do create disparities in prevalence, but also the way that our healthcare system is built, and implicit bias and just racism, honestly, built into these systems that lead to these disparities in prevalence, I think is such a crucial point, that as we continue on this work, kind of a second avenue is, how do we not just associate these with outcomes, but how do we really unpack these disparities and say, this is what's due to these structural factors, to structural racism, to implicit bias and individual racism, and how can we reduce disparities and reduce inequities in care? So that's another, I think, really important part. And every country looks different, and every country has different histories that lead to these inequities and disparities. And in the US, we think so much about the racism that's embedded in our laws and embedded in the history of this nation. And so every country and every care provider and you should look inward, right, and say, how does our structure of healthcare and how does my perspective of my patients, how has that been impacted by these structural factors, and how might that contribute to these disparities? So much to talk about, but another big avenue I hope policymakers and others will pay attention to is equity and disparities.
I completely agree, and I think I've already noted you down. We might have to do another one on this, specifically on these disparities, because it's something very close to my heart too. So I work with South London and Maudsley Trust, and we have a really, really big emphasis on disparities in healthcare, access to healthcare, higher rates of certain mental illness in people of ethnic minority, because, well, just like you're doing, we need to get this data and then, not just declare the disparities, but, what are we going to do about
Absolutely.
It, right?
Absolutely.
And let's be, honest and open about it. And when people feel often, I think, very nervous about even talking about these things. But if we don't talk about them, it's never going to get dealt with. If we've got good, clean data to, back up what we're saying, it's the sort of like, this is the place to start. This is great. And also, Yeah, people are always worried about saying the wrong thing. Well, don't worry so much, because if you're around people who want to make change for good, then it doesn't matter. Let's just, we can politely contradict each other, and that's cool, and let's just deal with it. And that, that's science, right?
Yeah.
So this is so get ready for the next episode with Wyatt. I actually haven't asked him yet, but I think he'll be all right with it. Thank you so much today, Wyatt. You've been an absolute star. This is fantastic, and I really look forward to reading your next paper.
Yeah, thank you so much for having me, and I hope people enjoy this, and thank you for the work that you do, Torie.